And thank you very much for everyone coming. My name's Ben, and I'll be representing Arthritis SA today. So I'd like to welcome everyone to our first webinar of 2023. I almost said 2022, as everyone does at the moment. And it's going to be about busting common myths around osteoarthritis with Dr. Felicity Braithwaite. I'd like to start today's session by acknowledging the Kaurna people, who are the traditional custodians of the lands on which Felicity and I both present on today. I pay my respects to the elders past, present and emerging. I pay that respect also to any Aboriginal and Torres Strait Islanders people who are here today. Now, Felicity, for those who don't know her, she will be talking around the topic about the negative myths and ideas around arthritis, especially osteoarthritis, and really the ones that we have in the general public. So what these myths can really do, especially the negative ones, can really prevent people with osteoarthritis from living their best life and really reaching those goals that we know they set. We hope that before you watch the video and responded to the survey that Felicity put out there. If not, we'll also be watching those videos tonight. Felicity and her staff greatly appreciate any of the feedback, and it really helps you help them help people with osteoarthritis, if that makes sense. Felicity will also be going over tonight some non-surgical research that has shown really positive results. A little bit about Felicity, and I know in her presentation she'll be kind of going through this as well. She's a postdoctoral researcher at the University of South Australia and a physiotherapist too. She's really passionate about improving the lives of people with painful osteoarthritis, and how going about this is really about partnering with consumers, so people who do have actual osteoarthritis, to produce really kind of meaningful and impactful solutions. So rather than just looking at the condition, it's actually trying to produce things that people can kind of understand and put into place. She's the inaugural John Stuart Colville Fellow from Arthritis SA. So this is from us here at Arthritis SA. It's really allowed Felicity to do her work and improve osteoarthritis knowledge, not just for those who have the condition, but really the entire general public. And it's really fantastic, some of the stuff that's coming out. Felicity also leads, she's a lead trial coordinator of a clinical trial looking into education and exercise and the positive benefits it can have people on their osteoarthritis and their pain. So I'll hand over to Felicity.
Thank you so much, Ben. A lovely introduction, and thank you all for coming tonight. I'm just going to share my screen and I'll just chuck this onto, oops. All righty. Does that all look good, Ben?
Looks very good.
Okay, good. All right, so yeah, my name is Felicity, and I'm going to be talking about some of the really common negative myths out there about osteoarthritis. And I'm going to be sharing some of the new science that has really changed the way we think about osteoarthritis that busts some of these myths. And I'll also be talking about some of the new non-drug and non-surgical treatments that have shown great benefits, along with some tips and tricks to help you get the most out of these treatments as well. But first, I thought I'd give you a little bit of a background about myself. As Ben mentioned, I'm a physio by background, but after I graduated my physio degree, I decided to follow my passion for research. And during my research career, I've always been really interested in chronic pain, and specifically osteoarthritis, for a couple of key reasons. First, as I'm sure you're all aware, OA affects the lives of just so many people around the world. And I think we could do a much better job managing it, not just by researching new treatments, but also through improving society's understanding about OA and all of the best management options out there. And second, I have a personal connection to osteoarthritis as well. So pictured here is my beautiful father. He had a hip replacement back in 2018, and unfortunately, it just didn't go very well for him. A few days after the surgery, the doctors thought that his hip was infected, so they ended up repeating the entire surgery a week later so they could clean it all out. And because of these two major surgeries happening so close together, it took him much longer than anticipated to recover. So it's now about 5 years later, and he still has quite a significant limp and has never really regained his pre-surgical fitness. So this really inspired me to focus my research on osteoarthritis. Often we only hear the success stories of surgery, but these kind of less successful stories also exist, and they're actually surprisingly common. So for example, you probably didn't know that around 20% of people who have a joint replacement surgery still have long-standing chronic pain after the surgery, and up to 30% of people are dissatisfied with surgery a year later. But of course, lots of surgeries do go really well as well. And when they're done for the right person at the right time, they can really change lives. But today, I'm just going to be talking about some of the new science that's showing us there's lots of other treatment options that we can try before going under the knife, because I truly feel it's really important that people are aware of all of their options before making that big decision to have joint surgery. And these treatments can also be really useful for people who have already had surgery too. So hopefully this applies to everyone. So obviously my dad's story was incredibly influential on my life and my career. And I think the power of people's stories is really important to ensure the research that we do is actually meaningful. So in 2020, I was really fortunate to receive a research fellowship via Arthritis SA that Ben mentioned, the John Stuart Colville Fellowship. And this allows me to conduct my own osteoarthritis research. And one thing that's really important to me is working with people with lived experience and hearing their stories to make sure my research really matters to people who have osteoarthritis. So as part of this fellowship, I've brought together an advisory panel of 6 people with osteoarthritis to help keep me on track. And in this talk, I'll be referring to them as osteoarthritis co-researchers. So today, as I mentioned, we're going to be talking about some of the common myths about osteoarthritis. And I want you to know that all of the myths that we'll be discussing today have been identified by these 6 people with osteoarthritis that I've been working with. So these are myths that they have directly experienced as part of their osteoarthritis management journeys. So hopefully you'll be able to relate to some of this. All right, before we get into some myth busting, I just want to mention a little disclaimer first. So the myths we're going to be discussing today are still very common. So you might have heard of them before and they probably won't surprise you. In fact, research shows that most people, and not just people with osteoarthritis, but also the general public, the media, and even lots of doctors and health professionals still believe these myths that we're going to be talking about today. And this is understandable because some of the science that has busted these myths is really brand new. So my hope for this webinar is for us to go on a bit of a journey together and explore these myths about what busting them could mean for you and your osteoarthritis. What this really means is that I hope that some of the new science and knowledge that I'm going to be sharing today offers some new hope. All right, so let's start with one of the most common myths out there. I've got no cartilage left and I'm bone on bone. I'm sure a lot of you have heard this one before. The phrase bone on bone is still being used by many health professionals, so you're definitely not alone if you've heard this. But why do we now consider this a myth? Let's have a look at the science. So the phrase bone on bone originated because of what we can sometimes see on scans or x-rays of knees and hips in particular. So here's an x-ray of a knee, and this is a very common finding, especially as we get older. So you can see here on the left side of the knee, there's a visible gap between the thigh bone above and the shin bone below. But on the right, there appears to be no gap and the bones really look like they're touching here. But now we've developed more sophisticated measurement techniques. We now know there's always a gap between the bones in all of our joints, even if it doesn't look like it on an x-ray. And no matter what your x-ray looks like, there's always some cartilage in there. Another really interesting fact that scientists have recently discovered is that around 43% of people who have no pain have signs of osteoarthritis when they get an MRI scan of their joint. And many of the things we see on the scans that sound quite scary are actually really common in people with or without pain and tend to just become more common as we get older. So things like degenerative changes or cartilage defects, these are commonly reported to be evidence of osteoarthritis when we receive a scan report from a radiologist. But this research is showing us that people without pain also have these findings. And this tells us that many of the things we see on scans are actually just normal age-related changes, a bit like wrinkles on the inside. And this is now being reflected in clinical practice guidelines as well. So these guide health professionals on the best course of action for a particular health condition, and they're based on all the best science available. So for osteoarthritis, the guidelines now state that an X-ray or scan is no longer required to diagnose OA. And instead, we can now diagnose it by asking questions and performing physical exams. Because talking to you about what you experience and seeing what you're able to do actually gives us way more information than a scan would in determining what treatment might work best for you. And here's a very common situation. Here are 2 X-rays of 2 different people's right knees. So one of these people has 7 out of 10 pain, while the other has 1 out of 10 pain. Can you pick which one is which from these scans? I certainly can't. You can see here there's a very similar amount of narrowing of the gap between the bones on the insides of the knees. So it's really actually impossible to tell who is in more pain from these scans because they're so similar. There are also people out there who have really severe looking scans, really severe looking osteoarthritis on their scans, but no pain at all. And so this is actually really exciting because it means that it's possible to reduce your pain and possibly even have no pain at all, despite what your scan looks like. So these new studies show us that changes on a scan often tell us very little about pain, but that doesn't mean it's wrong for you to have a scan if you've already gotten one. Sometimes they are required and they can provide really important information in some situations. So they're often still used when health professionals are trying to get as much information as possible. And lots of clinics still use scans to diagnose OA and as well as rule out other factors. But what I want you to take away from this new science is that scan findings should not be used as the only piece of information to dictate which treatment you should have. What your scan shows does not determine your future. And this means that there really is new hope, because new research is showing us that non-surgical management, particularly things like regular exercise and a healthy diet, are really effective at reducing osteoarthritis pain. And this is no matter how severe the person's scan looks. So scientists have busted the myth that osteoarthritis means you're bone on bone. No matter how severe your scan looks or how scary the words on the report sound, it's possible for you to have only a little or even no pain. And importantly, your scan does not dictate how well you will do with the right treatment. And I'll talk about some of the best treatments out there soon. All right, let's move on to the next myth. So when talking with my osteoarthritis co-researchers, they all said that at one point in their journey, they thought that joint replacement surgery was inevitable. But is this true? Does everyone with osteoarthritis eventually have to have joint replacement surgery? Is it really the only solution? Well, I'd like to introduce you to my mate Peter here. Peter was told he had severe osteoarthritis in both knees and that he needed surgery. But he wasn't too keen on surgery, so he decided to explore other options and he decided to try physiotherapy instead. And he found a particular program that involved walking, strengthening exercises and pain education, which was delivered over 12 months. Now, at the beginning of the program, Peter set what he called an aspirational goal. And this goal was to walk the Camino Trail in Spain. And he called it aspirational because he secretly didn't really believe he could do it. But to his surprise, by sticking to the program, he had completely stopped taking painkillers, stopped waking up at night with pain, and he achieved his aspirational goal. Peter walked 320 Ks in just 14 days. Would you ever believe that was possible with 2 knees with severe osteoarthritis? It's just so truly incredible and inspirational. And Peter even got to tell his amazing story on the news recently. So I've got a little clip here to show you from that news story.
A grueling 320-kilometre hike over 14 days, an impressive feat for anyone, let alone for 66-year-old Peter Ninnis, tackling Spain's Camino Trail with severe osteoarthritis in both his knees.
It's hard to describe. I mean, it was very emotional, tremendous sense of achievement.
It was a goal 2 years in the making. Peter set his sights on the trek after signing up for a Uni SA study in 2020, exploring ways to manage joint pain through physio and exercise treatments.
I was already thinking that if I could avoid surgery, that would be great. And I just like the idea of a more holistic approach.
Pretty cool, huh? So new research is showing us that education, exercise and weight management are highly effective at reducing pain and improving function and quality of life of people with osteoarthritis. And this means that now all the biggest and best clinical guidelines recommend that everyone with osteoarthritis try these treatments before having more invasive medical treatments such as surgery, because these treatments can delay and even prevent surgery altogether. So we've now busted the myth that surgery is the only solution for osteoarthritis. With the right management strategies, it's possible to live a normal, happy, healthy life without going under the knife. All right, here is another very common myth that we still hear all the time, that exercise makes OA worse because OA is a wear and tear disease. So I've been working with my osteoarthritis co-researchers to create a short video explaining why this is now considered a myth. So I thought I'd share this video with you all today. And apologies to anyone who's already seen this video, as it was part of the survey we did send out before this webinar. Thank you so much for those who did complete the survey. I really, really appreciate it. The video goes for about 3 minutes. And yeah, I would love to hear any feedback that you have on the video. There'll be a survey sent out after this webinar as well with a question around that. So please be honest and tell me your true thoughts. I'd love to use that feedback to improve it. And I also just want to point out that this video focuses on knee osteoarthritis, but the principles are relevant to OA of other joints as well. All right.
Cartilage is a tough stuff that sits on the surface of your leg bone. You may have heard of it before. If you have osteoarthritis, you might have even been told that your cartilage is damaged or has become thinner and that your joint is now bone on bone. You may have also been told that osteoarthritis is a wear and tear disease. And so the more you do with your knee and the more you exercise, the more you might wear out your cartilage. And once it's damaged, you're stuck and you're going to need surgery. But is that true? What you might not realize is that cartilage doesn't actually stay the same. It can get better. Let's investigate. Did you know that when astronauts go into space, their cartilage gets thinner? Wait a minute. So when there's no gravity, no load on their knee, so no possibility of wear and tear, the cartilage gets thinner and less healthy. And did you know that runners often have healthier cartilage than non-runners? Wait a minute. So when there is lots of load on their knee, the ultimate wear and tear situation, their cartilage gets healthier? What's going on? Scientists have recently discovered that cartilage repairs throughout life. Cartilage is provided with the nutrients it needs to be healthy by the fluid within your joint, called synovial fluid. Your knee needs movement, and compression like walking pushes the fluid and nutrients towards your cartilage. Cartilage is like a sponge. Compression pushes the fluid out, but when compression is released, cartilage will suck fluid back in. Cartilage building cells in your knee called chondrocytes are also happiest with movement and compression. They thrive, they reproduce. So exercise, such as walking, keeps your cartilage healthy and can even stimulate cartilage repair when needed. For example, when cartilage may have become thinner due to osteoarthritis. This explains why astronauts' cartilage becomes thinner while in space. Without gravity, their cartilage isn't exposed to the usual forces of movement and compression. However, within a few weeks of being back on Earth, their cartilage returns to normal thickness. And this also explains why runners have famously healthy cartilage. Their cartilage is exposed to far more movement and compression than the average person. Studies show that regular running does not damage cartilage. In fact, runners are 17% less likely to have knee osteoarthritis than non-runners. But you don't have to be a runner to keep your cartilage healthy. Even regular walks in the park with your loved ones can be enough. All of this means that movement and exercise are great for your cartilage, and being more active can help you no matter how severe your osteoarthritis is. So cartilage can actually repair. Scientists have busted the myth of wear and tear. Instead, now we say wear and repair. It's all about finding the right place to start.
All right. So as the video explained, exciting new science is showing us that OA should no longer be considered a wear and tear disease. And this is largely because exercise is really proving to be one of the best treatments for osteoarthritis. But time for another quick disclaimer. I fully acknowledge that exercise can be really, really hard, especially when you're in pain. You might have even tried an exercise program before, but it just made your pain worse. And this is very common. So I'm now going to share with you some of the tips and tricks to try to help make exercising a bit easier and hopefully more effective. So let me introduce you to the sweet zone. Your sweet zone is the perfect amount of physical activity for you and your painful joint at this moment. It's completely unique to you and it's under your control. You know you're in the sweet zone when you're working a bit harder than normal, but not so hard that your pain or swelling flares up and doesn't settle down quickly after you stop. And you may not know this, but all of the tissues in your body are bioplastic, and this means they can change and adapt, but they need a nudge, and this nudge is what makes your body respond and become stronger and fitter. And one of the best nudges for your body is being physically active. It's beneficial for so many things, from the cartilage in your joints, to your muscles, to your lungs, your heart, and your brain. And being in the sweet zone also triggers the release of feel-good chemicals in your body called endorphins. These can improve mood, increase your energy, and can even be natural painkillers as well. So now I have another short video to share with you that I created with the osteoarthritis co-researchers to explain the sweet zone a little bit more.
You know you're in the too little zone when you aren't doing enough activity that makes you breathe a bit harder than normal. In the too little zone, you don't have a big enough nudge. This means that your activity level is too low to maintain the health of your body and your knee. Your health can even go backwards. It's like you've been unwell and bedridden for a few days. It's harder to walk and move around than it is before being sick, isn't it? We don't want to stay in the too little zone. And you know when you're in the too much zone, when you're doing activity faster, harder, and longer than your body is ready for. In the too much zone, your activity level is too high and you may experience more pain or swelling than normal. But it's important to remember, this does not mean you've damaged your knee, and it's just your body's way of telling us, we've overdone it. Your nudge is too big. It's like when someone tries to run a marathon without any training. Their body has got to hurt. You need to slowly work up to higher activity levels. Have you tried to increase your activity level and found that it didn't work for you? It just made your knee hurt more? This is very common. Take a moment to reflect. Maybe you were in the too much zone. The key is to slowly but surely increase your activity level over time. This way you continue to nudge your body so that pretty soon you can do more activity with less pain. When increasing activity, you may get a slight increase in pain as your body adapts. But if you're in the sweet zone, this pain will go away quickly afterwards. Identifying activities that are meaningful to you is really important because you are much more likely to keep doing activities that you enjoy.
Okay, so to summarize some of the key tips and tricks from the video, it's really important to find your unique sweet zone because it's different for everyone. So this red arrow represents how much activity you're currently doing. The goal is to move the red arrow towards the upper edge of your sweet zone, and over time, your entire sweet zone will shift as you gradually build up your activity level and your body adapts. And this means you'll be able to do more activity with less pain. So sometimes this is called graded activity or pacing. The key is to slowly but surely increase your activity level over time. And here's a diagram of what this might look like for a graded walking program. So in week 1, you might go for 3 walks to find your sweet zone. This means how far you can walk before you experience a significant increase in your pain, or pain that is likely to last for some time after you finish walking. We usually say around 2 hours or more. And then once you've completed your 3 walks, you calculate the average duration, and that's your current sweet zone. So for example, if you walked for 8 minutes, 10 minutes, and then 12 minutes, your sweet zone would be 10 minutes. Then in week 2, it's a good idea to start a little bit below your sweet zone to give your body time to adapt to your new routine, especially if you haven't been doing much activity before you start this sort of program. So if your sweet zone is 10 minutes, in week 2, you'll do 4 to 5 walks that last for 8 minutes, which is 80% of that 10-minute sweet zone. Then each week you progress by increasing the duration of your walks by 10% until you reach your goal. We usually recommend 5 30-minute walks per week as a good goal to set, because this is the activity level recommended by the Australian government and experts for health benefits. So it's all about gradually increasing your activity level so your body has time to adapt. And it's really important to stick to the plan despite how you're feeling. So this means not doing less than planned, even when you're having a bad day, but it's also equally important to not do more than planned, even when you're feeling really good, because this can push you into the too much zone before you even realize. So when increasing activity, you might get a slight increase in pain as your body adapts. But what's really important to remember is that this pain does not mean you've damaged your joint. It's just our body's way of telling us that we've overdone it a little bit. And this is why it can sometimes feel like exercise is not working for you and it's making your pain worse. But it's all about recognizing that some fluctuations in pain is normal, especially when you're starting out and figuring out your unique sweet zone. And as you can see, this is no quick fix. It does take time and consistency to reap the benefits of an exercise program. But research is clearly showing us that people who stick with these sorts of programs can have life-changing results, just like Peter did. In fact, this is the actual walking program he completed that took him all the way to the Camino Trail in Spain. As the video mentioned as well, it's also really important to make sure you choose activities that you enjoy, because you're much more likely to stick with the program and keep doing that activity over the long term. So most people choose walking because it's free and you can do it anywhere. And it's so important for our daily lives to be able to walk distances, for example, walking around the shops. But you can apply the sweet zone principles to any activity: cycling, swimming, strengthening exercises, you name it. Setting short-term and long-term goals are also a really great way to keep yourself on track, motivated and accountable. And also to feel that really great sense of achievement when you reach your goals, just like Peter did. And finally, recent advances in pain neuroscience have shown that so many different things can contribute to the pain that we feel, not just what's happening in the painful joint. So some of these might seem quite surprising. For example, the things you hear, see, smell, taste, and touch, things you do, things you say, things you think and believe, the places you go, and the people in your life can all have important influences on your pain. Some of these can be negative and increase pain. We call these DIMs, or danger in me. But also some of these can be positive and help reduce pain, and we call these SIMs, or safety in me. So for example, have you ever noticed that your mood can have an impact on the pain you're feeling? To illustrate this, I want you to imagine 2 different scenarios in which you stub your toe. In the first scenario, you're at a party, you're having a great time, dancing and laughing away with your friends, and then you stub your toe. Sure, it hurts, but you only notice it for a moment and then you continue to have fun and party on. Now, in the second scenario, you're at home, you're alone, you're in a terrible mood because you've had a really, really bad day at work, and you're already on the verge of tears, and then you stub your toe. How much more does it hurt in that second scenario? Despite the same amount of toe stubbing stimulation, the experience of pain is completely different, right? And we can really use this knowledge to our advantage. One thing we teach people in our educational treatments is to explore their personal DIMS and SIMS, and this knowledge can help make exercise easier. So for example, you could boost your SIMS by going for a walk in your favourite park with your best friend, and these things could help reduce the pain you feel while you complete your walks. If you want more information, then check out Noi Group. This is a pain education company based in Adelaide, and they have lots of great resources about pain management based on the most recent scientific advances. So this book here will be released really soon. It's called the Explain Pain Handbook for Knee Osteoarthritis, and it talks about how to find your sweet zone and the DIMS and SIMS in detail. It is specific to knees, but all of the principles are very relevant to osteoarthritis in other joints as well. And Noi Group also have lots of other fantastic resources for chronic pain management in general as well. So I encourage you to check them out. All right, so here's the final myth I want to share with you today. My OA is only going to get worse and there's no hope. Of course, everyone's OA is different, but because there are many things that can contribute to the pain experience, not just what's going on in the joint or the cartilage or what we see on a scan. And this is really exciting because it means there's so much potential for improvement that was never realized before. So I really hope that through everything we've talked about today, I've busted this myth, and there are many things you can do to improve your osteoarthritis, and it doesn't have to be surgery. So I've just popped my email up on here. Please do get in touch if you are interested in being part of our osteoarthritis research, or if you want help finding some resources that will guide you in some of the things I've talked about today. I'd be more than happy to help. And I just want to acknowledge all my supporters with this research, the Body and Mind Research Group at the University of South Australia, of course, the Arthritis Foundation of South Australia for providing funding support, my animator Josh Hobbs, my collaborators, and of course my wonderful osteoarthritis co-researchers as well. Thank you very much. That's the end of my talk.
All right, I'll jump back in. If anyone has any questions for Felicity, because we'll have her for a little bit if anyone wants to ask anything. We've got the Q&A function open, and we'll see if any come through. I mean, that was a fantastic presentation. I learned a lot, and I deal with osteoarthritis each and every day. That was really, really good.
Thank you.
Is there anything, I guess my first question is what we always hear a lot about. Is there any tips that you can go through for really people just starting off, like from baseline? So if anything's kind of really resonated with someone today, what should they kind of do tomorrow to really start that journey?
Yeah, that's a great question. I think the walking program that I went through in my talk today is a great place to start, but also making sure you start with that knowledge that pain doesn't equal damage. So when you're starting a new exercise program, it can be painful, and just acknowledging that that's normal, and it's our body just reacting to an increased amount of activity level, and keep going. Because often we do see people who are just starting out who will attempt a new exercise program or a walking program. They'll feel some pain, they'll think that they've caused more damage to their joint, and then they'll obviously stop, and that makes complete sense. But it's really about truly understanding what's going on in your body, what pain actually means, and then really gradually increasing your activity level, like I explained with that diagram today. I think that would be my biggest tip. Yeah, I think we see so many people who attempt exercise programs, and I'm guilty of this as well. You get excited when you're starting something new and you just do too much too soon. And then you think, oh, that's not going to work for me. Very logical conclusion, but we just want to sort of train people to take it more slowly and have that knowledge equipped with them as well before they start something like that.
Sure. So we've got some questions coming in and we'll get to them. So the first one is about nutrition tips. Now, if that sits out of your what we call scope of practice, I'm happy to jump in there with that one, but up to you, Felicity.
Yeah, I guess like it is. I'm not a nutritionist or a dietitian, but there is some really exciting research coming out showing that a healthy diet is obviously really important for osteoarthritis, and particularly a low inflammatory diet. So we're starting to understand that osteoarthritis is a systemic inflammatory condition. So it's a low-grade inflammation throughout the whole body. And that's why we think that weight management is so important for osteoarthritis as well. It's not just about reducing load through the joint, but it's actually also about reducing inflammation throughout the body. So that would be, yeah, my comment on that. Over to you, Ben.
I'll jump in from Arthritis SA. So number one tip I'd say for everyone, if you've got these specific questions, especially around nutrition and things, is to contact our information line. And that's 1-800-011-041. And we're open 9 to 5, Monday to Friday. And our big thing, especially with osteoarthritis, is it's the general kind of, it is that anti-inflammatory diet to a certain extent, but we really focus in on the Australian Guide to Healthy Eating, because really we know that it's the general kind of things that everyone's heard probably at some stage of their life, if that's at school or getting a little bit older, is really that kind of, especially that idea of 2 and 5 protein, and then there's that mixed diet is really the best thing you can do for your osteoarthritis for nutrition tips. But if you contact us at Arthritis SA, we can actually, have a longer conversation and send you out a lot more specific information. The second one is, does UniSA have another similar program or any agencies that people can contact in Adelaide?
A similar program to the clinical trial, I'm assuming you're talking about there.
I believe so.
Yeah, unfortunately that we've finished recruiting for that particular trial, but definitely send me an email and I can put you on our database for new studies coming up. So should I share my email again, Ben, or like, can we send that out somehow?
I can send it out afterwards, that's all right.
Yeah, perfect. So yeah, if you just send me an email and then we can put you on that database and we'll contact you when something that you might be eligible for comes up.
All right. So the next one is it's someone who experiences wrist osteoarthritis, and they say that if they don't exercise or if they do exercise, the wrist burns and stings every night. Is there a specific reason for that?
Yeah, good question. I think, so are you saying it burns and stings? I don't know if we can have any back and forth here, but if it burns and stings with exercise, was that the question?
If they don't exercise, or even if they do exercise, so kind of both, they're having those experiences. Okay.
So this is where the sweet zone might actually come in. If you're in the too little zone, you can stiffen up and have a bit more pain, but also if you're in the too much zone as well. So I think maybe just finding the right amount of movement for your wrist and the right amount of load and gradually building it up from there rather than just all or nothing. That's the best way to approach it, and see if that helps. And use the same principles that I spoke about with the walking today as well. So figure out where your sweet zone is, do some exercises. If you have a big flare-up of pain after that exercise that doesn't quickly settle down, so like I said, about 2 hours after you stop exercising, that means you've gone into that too much zone. So yeah, figure out where that line is for you and start at 80% of that and see how you go with that, I'd suggest.
Perfect. Now, the next one might be a more difficult one, and it might be a more occupational therapist question, but we'll see how it goes. So someone asks, when they go to work, they walk too much and they go over that sweet zone, and it takes a day or so to recover. They can't avoid this at work. Is there any tips or is there anything they can do to help that?
Yeah, that's always very tricky when you can't avoid doing too much. I guess if there's any way that you can break it up, so you could break up that walk to work into smaller chunks and have little rests in between, and then maybe build into the rest of your life if you have time. I know that's hard as well, but build into the rest of your life a bit more physical activity so your body can adapt to that level that you need to do for your work. They'd be my main suggestions. Yeah, it's always really tricky with, life and routines and things like that. And that's why exercise is so hard for people. But yeah, it's all about finding a way to make it work for you. And yeah, I think probably my best tip there would be trying to break it up a little bit and doing smaller chunks if that's possible.
All right. The next one is from someone who's had a knee replacement and their surgeon told them that they were never to run again. They say that they can run short amounts. Is there a good reason why they shouldn't run?
So not knowing your medical history and things like that, I probably can't really comment on that. If it's all went well and it was a normal surgery and there's no other health issues and, you know, it all healed up nicely and all of that, I can't imagine there's a reason why you couldn't. But yeah, I'm not a surgeon and I'm not sure about your medical history, so I'd be hesitant to comment further on that one.
Good answer. The next one is that someone has hip and hand arthritis, and then especially in the fingers. They were told that their finger joints are different to larger joints like the hip, and they shouldn't try and strengthen their hands or fingers like they have in their hip. Is that true? Is there any difference between those strengthening those kind of bigger joints like your hip and versus those smaller joints like your fingers?
Definitely not. All of our joints love movement. All of the cartilage in our joints and the chondrocytes are stimulated by movement and load. Like we saw in the video, we saw the example of the astronaut, and they don't have that load going through all of their joints, and the cartilage thins throughout their body. And then when they return to Earth, it all normalizes. So this translates to every joint in your body. I'd encourage as much movement as you can do within that sweet zone. I don't know who gave you that advice, but I think you're very safe to move your hands and exercise them as long as you follow that graded activity sweet zone sort of principles.
Now I'll jump in here because we're getting some questions about medicines and kind of those treatments and things like that. So Felicity is mainly focused in, as she kind of said at the start, in physiotherapy, so mainly kind of exercise and things like that. But we will have, if you want to kind of answer those questions, calling our info line is probably the better one for those ones, mainly because we have people who kind of specialize in medicines and things like that, rather than kind of exercise and pacing and things like Felicity's going over. So as much as we'd love to answer those questions, it gets a little bit difficult because we're not the healthcare providers to answer those ones. All right. Just leaving it open to see if anyone else has got anything to ask. Right. Well, I'd like to thank everyone for coming along, especially Felicity. It's been a fantastic presentation. As any conversation with you about osteoarthritis, I learned something new, so it's really good. There will be a short survey afterwards. If everyone's happy to fill that out, it'd be really good. And then if anyone wants to get in touch with Felicity, if you send me or kind of anyone, if you call up the info line tomorrow and ask for her contact information, we'll be able to provide that and pass that on. Thank you very much. I hope everyone's enjoyed tonight. We'll have webinars coming up in the future, so we're probably going to do it every about 2 months or so from Arthritis SA. Really appreciate your time and hope you enjoy the rest of your night.
Thank you so much, everyone.